I would come to go ahead with the topic of management of hypertension and diabetes. See, most of us are diabetologists, most of us are treating hypertension, and we have got the importance of what hypertension is just now. We know we just went across how to see how you will take a blood pressure management, then you went how to take a blood pressure, then we saw how isolated systolic hypertension should be managed, then Dr. Singh was telling about end-stage renal disease and hypertension. Today, I'm here to talk to you something about the hypertension and diabetes. I see many of the people are also diabetologists here, because many people who travel with me practice diabetology alone, and some people practice hypertension alone. So we join them together. So we find that hypertension is purely, and as already mentioned, is very sparsely identified in many of the population, can significantly accelerate the development and progression of both the micro and the macrovascular complications. Whenever we talk about diabetes, we think about the microvascular complications, or we look into the macrovascular complications. So we need to aggressively, as the inaugural speech was given by Mr. Joshi, he said, you have to bring down hypertension. He says he's sending vans everywhere to measure the blood pressure of people. So it is highly essential that we have to bring down hypertension so that we have to reduce the healthcare cost also. Today, nearly 2/3 of the people with diabetes do not have blood pressure readings under their target range. They don't come under control. They keep coming once in a way, get their blood sugar checked, but the hypertension does not come under the control range. So we need to effectively bring down antihypertensive regimens that will be helpful to treat hypertension in diabetes, the setting of diabetes. We find in this slide that in the association of systolic blood pressure, which is already mentioned by Dr. Ramesh, he said what is systolic blood pressure and how its importance. You find that systolic blood pressure in men with cardiovascular mortality is high when the blood pressure rises. So we'll be looking into all of this down the thing. Initially, we will be looking at the epidemiology, the factors favoring hypertension and diabetes, the rational management of hypertension and diabetes, a few clinical trials I'll run through for want of time, and how to get a target blood pressure in diabetes. 20.6% of the Indian patients have hypertension and diabetes coexisting. That's very important. 75% of the people in the world with diabetes have hypertension. Of course, most of us, as Dr. Singh was saying, everybody is going to go have something, no salt and all the food that we are going to take. You have obesity in and around independent predictor of hypertension. 40% of the patients with hypertension have a BMI of more than 30. Microvascular and macrovascular complications are more common in patients with diabetes who also have hypertension. Along with hyperglycemia, dyslipidemia, and cigarette smoking, most of us know that all these are cofactors that are related to the progression of the disease. Hypertension is a major contributor to the development and progression of macrovascular and microvascular complications in people with diabetes. Compared to the general population, people with diabetes face a 2 to 4-fold increase of cardiovascular risk. So concomitant hypertension, it adds to it and it triples the already high risk of the disease. Here you find in normal, when there is no diabetes, you find that as the blood pressure increases, you find that people have more of cardiovascular events that can occur, both men in the female, in smokers and non-smokers. The comparative data has been put where you have a lesser risk in women, but more in men. In diabetes, you find that the red boxes are more high, because as the blood pressure rises, the incidence of cardiovascular events in 5 years also increases dramatically. Hypertension significantly accelerates the progression of diabetic nephropathy, retinopathy, and neuropathy. All of us know about it. Of particular importance, a systolic blood pressure is a stronger predictor than diastolic blood pressure for both cardiovascular disease and renal complications. In people with type 2 diabetes, the prevalence of hypertension is 50% at the time of diagnosis. So we'll have to identify it, increasing to 80% in the presence of microalbuminuria and to 90% with macroalbuminuria. Although population-based data are limited, between 30 and 43 of the adults with type 1 diabetes also have concomitant hypertension. Onset of hypertension in these patients frequently correlates with onset of albuminuria. Now let's look into the factors that are favoring hypertension in diabetes. The main factor is hyperinsulinemia, volume expansion, increased arterial stiffness, and of course diabetic nephropathy. Hyperinsulinemia is due to insulin resistance, mainly in type 2 diabetes, or to insulin administration, may increase the systemic blood pressure. In a study that was conducted in 80 people of type 2 diabetes, began on insulin, the blood pressure rose from 132/81 diastolic to 150/89 millimeters of mercury. This hypertensive response, although not noted in all studies, may be mediated by concurrent weight gain that has been noted in patients who are on insulin. Hyperinsulinemia may be a link to explain the association between obesity and hypertension in both non-diabetic patients and those with type 2 diabetes, since insulin can increase sympathetic activity and promote renal sodium retention. The second factor which I mentioned is volume expansion. Here you find that sodium retention and volume expansion may be induced both by insulin and the hyperglycemic state. The excess filtered glucose is reabsorbed and in the proximal tubules via sodium glucose co-transporter, resulting in a parallel rise in the sodium reabsorption. Then salt loading tends to raise the blood pressure, on effect that can be reversed when we advise the patient on salt restriction. The third factor is the increased arterial stiffness. Patients with diabetes can have a increased vascular stiffness. This is thought to be a consequence of an increased protein glycation, and at a later stage it can go on to form an atheromatous disease. The reduction in arterial distensibility, which is seen with both impaired glucose tolerance and overt diabetes, can contribute to the rise in systolic pressure and is associated with mortality risks. The last factor which I mentioned of the four is diabetic nephropathy. Hypertension is highly prevalent in patients with diabetic nephropathy. Diabetic nephropathy is the leading cause of chronic kidney disease and end-stage kidney disease. And the etiology of hypertension in diabetic nephropathy involves mechanisms with multiple interrelated mediators that result in renal sodium reabsorption and peripheral vasoconstriction. We have been talking much about the metabolic syndrome, and we attribute the risk factors of abdominal obesity, elevated blood pressure, elevated fasting glucose, elevated triglycerides, and low HDL-C levels. Angiotensinogen from fat cells can increase angiotensin II and thus also increase blood pressure. Both systolic and diastolic blood pressure increase with increasing body mass index. Today our problem is obesity, and we want to control obesity in various methods. People go after gyms, they try to reduce their weight, they reduce their diet, but somehow a rebound diet situation occurs, so they counteract for whatever food they take at a lesser time. So you find that there is subcutaneous fat accumulation, abdominal muscle layer also has accumulation, and also intra-abdominal fat can also accumulate. What is the role of abdominal adipocytes in insulin resistance and heart disease? You have abdominal adipocytes, there is increased adipocytokines and fatty acids, insulin resistance, which can lead on to a metabolic syndrome, and lastly, they all can lead on to heart diseases. The increased visceral stores, they can increase portal free fatty acids, hepatic insulin clearance, increase plasma insulin, and increase renal sodium reabsorption, leading on to hypertension. Can have a vascular constriction, which can cause hypertension, and of course the RAS, the angiotensinogen, angiotensin 1, angiotensin 2, which all can lead to vasoconstriction, leading on to hypertension. So this is the picture which all of us know, the angiotensinogen 1, 2, and how the ACE inhibitors, the angiotensin converting enzymes, the angiotensin receptor blockers act. Now, what are the effects of angiotensin 2? They have a pressor effect, a pro-inflammatory and promotion of inflammatory response and atheroma, increased oxidative stress, increased sodium reabsorption, increased insulin resistance through all the factors that I mentioned there. There is also a reduction in the nitric oxide production with endothelium. There is increasing vasoconstriction and also the increase in the TGF beta. What are the effects of obesity? You have a monocyte infiltration, ectopic fat distribution in various places, increased fatty acid production associated with cardiac insulin resistance and fibrosis, decreased adiponectin. This adiponectin exhibits potent anti-inflammatory and anti-atherosclerotic effects. All this picture most of you would have seen, the TV size which is decreasing and the man which is increasing. The cardiometabolic syndrome, which involves the visceral obesity, enhanced liposis, free fatty acids, all the factors given above, and there is also an increased central fat, endothelial dysfunction, hypertension, albuminuria, which all can lead on to atherosclerosis. Patients with insulin-dependent type 1 diabetes are prone to develop nephropathy, often have a familial predisposition. And they also can have sodium retention occurs as a characteristic alteration in type 1 or type 2 diabetes. Exchangeable body sodium is increased by 10% on an average. This abnormality develops in uncomplicated stage of diabetes and differentiates diabetic from non-diabetic essential hypertensive subjects. The role of sodium retention in diabetes-associated hypertension is supported by positive correlations between systolic or mean blood pressure and sodium concentrations, and by the normalization of blood pressure after removal of excess sodium by diuretic treatment in hypertensive diabetic subjects. Additional factors that are favoring hypertension in diabetes is the increased sympathetic tone, the endothelial dysfunction associated with hyperglycemia, and also the genetic factors. Now, what is the rationale of management of options for treatment of hypertension in diabetes? So many things going around, so many drugs available, so many molecules as on date, so many clinical trials that are coming or still on. JNC 7th and 8th is still in the annual. We are waiting for it. As already mentioned by Dr. Ramesh, he said it's still coming. For the last 1.5 years, we've been waiting for it. Many comorbidities, varied outcomes of interest, and a lot of cost constraints. What are the benefits of early detection and treatment? We have to prevent cardiovascular disease. We have to minimize the progression of the renal disease, to minimize the progression of diabetic retinopathy. And among patients with type 2 diabetes, the benefits of tight blood pressure control may be great or greater than the benefit of strict glycemic control. So the inhibition of the RAS and the prevention of diabetes complication nephropathy. So way back in 1993, various things that are published, that's decreased proteinuria, decreased time to dialysis. AC inhibitors and angiotensin receptors have demonstrated improvement in renal function. I think much will be spoken about this tomorrow, about AC inhibitors and all the drugs. So I will just touch on that. I'll run through rapidly. Renal protection has not been shown for patients without hypertension or microalbuminuria. So as the blood pressure increases, you find that the proteinuria also increases. This is just to show that as the blood pressure increases, you can have increased proteinuria. You find it in the subject in the slide. Inhibition of RAS and the cardiovascular disease in diabetes. Trials for prevention of cardiovascular endpoint required larger patient population than those used to study nephropathy. These have subsequently shown that cardiovascular endpoints are improved with AC inhibitors and angiotensin receptor blockers. So the various studies that have substantiated to identify the ideal drug have been mentioned. The UKPDS study is a long study with about 1,148 patients randomized to right control and less tight tight control and less tight control. The tight control is defined as a blood pressure of less than 150 by 85, and the less tight control is defined as a blood pressure of more than 180 and 150 of diastolic. So you will find in the end of the study that of 758 patients allocated to tight control, 400 were on captopril and about 358 were on atenolol. The agents were equally effective in lowering blood pressure, so both were equally good. Similar effects on reducing macrovascular events and microvascular complications were seen. These benefits required continued maintenance of a lower blood pressure. The greater reduction in blood pressure and the lower risk of complications in patients assigned to tight blood pressure control was lost within 2 years of termination, and the significant improvements in clinical endpoints were not sustained. So this is the graph that shows the tight BP control and the less BP control. and the implications that can occur because of that. The second trial is the HOT trial, the hypertension optimal treatment, where about 18,790 patients from 26 countries between the age group of 50 to 80 were seen. They mainly concentrated on the diastolic blood pressure. You find that the diastolic blood pressure of 90, 85 and 80, and they found it was best to maintain the patient on a diastolic blood pressure of 80. The third trial is the ABCD trial, the appropriate blood pressure control in diabetes. They compared intensive versus moderate blood pressure control on the incidence of progression of complications in type 2 diabetes. 470 patients with entry diastolic blood pressure of more than 90, followed by for about 5 years. The compared effect of calcium channel blockers versus AC inhibitors was found. Endpoints were change in creatinine clearance as primary and development of microvascular complications and cardiovascular disease were secondary. The other trial is the ABCD trial. The results were the BP attained for the last 4 years. It was seen that about 132 by 78 millimeters of mercury for intensive and about 138 by 86 millimeters of mercury for the moderate. There was no difference in the creatinine clearance between moderate and intensive, no difference between groups in those that progressed from normal to microalbuminuria or micro to macroalbuminuria. There was intensive therapy had a lower overall incidence of death, no difference in progression of retinopathy or neuropathy, and there was no difference in results based on calcium channel blockers or ACE inhibitors. The on-target trial, most of us know about this trial because we were all trying to combine both an AC inhibitor and an angiotensin receptor blockers, but no definite endpoint was received. Individually, both the drugs are good and they can be used together. The HOPE trial, the heart outcomes prevention evaluation trial, the objectives to evaluate the effect of ramipril on the prevention of cardiovascular composite endpoint of death from cardiovascular causes, myocardial infarction or stroke. The HOPE results, we found that ramipril treated patients reached primary endpoint at rate lower than placebo, and ramipril reduced rate of death from any cardiovascular cause. So the HOPE trial, you can find the placebo and the effect on ramipril, which was much better. The ADVANCE trial, the action in diabetes and vascular disease, there were various centers that were selected. It found that death from cardiovascular disease, non-fatal stroke or non-fatal MI, new or worsening renal or diabetic eye disease, and the study was conducted for about 4.43 years of follow-up. Compared to placebo, there was a drop in the pressure about 5.6 to systolic and 2.2 diastolic millimeter of mercury. There was not a significant decrease in the macrovascular events or microvascular events, and there was a 9% decrease in combination. There was a decrease in the cardiovascular death and death from any cause that could have been mentioned. The ACCORD trial, the action to control cardiovascular risk in diabetes, this also there was no difference between groups in terms of reaching the primary outcome composite. There was a decrease in the rates of stroke and lesser rates of progression of albuminuria. There were more adverse events in the intensive group, and this study has been a source of commentaries and discussion about how far to go with BP lowering. Combination therapies have been used, calcium channel blockers, whether they combined with angiotensin receptor blockers. These trials have all proved in different ways that they are very useful to use the drugs that we just mentioned, either an angiotensin receptor blocker, a AC inhibitor, a beta blocker, or a calcium channel blocker. So other studies, I'm just going to mention them and run through the studies of left ventricular dysfunction, the use of enalapril, and the advantage of losartan and atenolol, the comparative studies that have been done, the ALHART study, and the roadmap study. So I'll just conclude. Before concluding, I will go through the various trials and studies that have been done, the role of olmesartan that we are using currently. Already people have mentioned about the non-pharmacological methods of therapy, sodium restriction. It has been tested that the diabetic population's control trials, however, results from the control trials is essential hypertension have shown a reduction in the systolic blood pressure and the diastolic blood pressure. Also, sodium restriction, a daily intake of about 200 millimoles should be advised for these patients. A dose-responsive effect has been observed with sodium restriction even when pharmacological agents are used, there is often a better response when there is concomitant salt restriction due to the aforementioned volume component of the hypertension that is almost always present. The efficacy of these measures in diabetic individuals is not very much known. Physical activity, as already mentioned, very important. Smoking cessation, all these play an important role. And the current ADA recommendations for treatment of blood pressure says blood pressure should be measured at every clinic visit. Patients found to have blood pressure of more than 130 at the range of 130 to 80 millimeters mercury and confirmed on a separate day have hypertension and should be treated. So you should start treating these patients. So as mentioned, lifestyle interventions, weight loss, sodium reduction, moderation of alcohol, and increased physical activity. Pharmacological therapy for patients should include either an AC inhibitor or an angiotensin receptor blocker. Also recommend for patients with persistent microalbuminuria or higher levels of albumin excretion. Now, looking into this algorithm, treatment of hypertension in association with diabetes, if diabetes with nephropathy, without nephropathy. With nephropathy, the threshold equal of about 130 to 80 millimeters of mercury and target below that should always be maintained. There should be with nephropathy an AC inhibitor or an angiotensin receptor blocker. Without nephropathy, you go in for an AC inhibitor or a thiazide group of diuretic, or you go have you have a combination of two drug combinations. In concluding, the treatment of hypertension in diabetic patients was associated with significant clinical benefits in 3 major randomized trials: the UK-PDS trial, the HOT trial, and the ADVANCE trials. So major guidelines published before by the Accord BP suggested that the goal blood pressure in patients with diabetes mellitus should be less than 130 by 80 millimeters of mercury. The Accord BP trial of patients with type 2 diabetes at increased cardiovascular risk found no significant cardiovascular benefit and more drug side effects at a mean attained systolic pressure of 119 compared to 133 millimeters, with the exception of a reduction in stroke. A number of other studies have found that the incidence of stroke, but not coronary disease, continues to fall at systolic pressures below 125 to 130 millimeters of mercury. The choice of antihypertensive agents in diabetic patients is based upon their ability to prevent adverse cardiovascular events and to slow progression of renal disease if present. The choice is not based upon retinopathy endpoints, since comparative trials have not demonstrated superiority of one agent over other in retinopathy. A good blood pressure of less than 140 by 90 is recommended compared with higher pressures. A goal blood pressure of less than 130 bar 80 millimeters is recommended compared with higher pressures in patients with diabetic nephropathy and proteinopathy. There is no data that supports that use of AC inhibitors or ARBs prior to the development. So when if a diabetic comes to you without hypertension, you need not start them on an AC inhibitor, an angiotensin receptor blocker of hypertension prevents or microalbuminuria. Further, lowering of blood pressure to values of less than 120 by 80 millimeters of mercury is not associated with an improvement in cardiovascular events and is associated with increased side effects. So to conclude, may we have the melody, you become the melody for the hypertensive and the diabetic patients.
Thank you, Professor Moses.